This is Sg2 Perspectives, a conversation with Sg2 experts and industry thought leaders about the biggest trends in healthcare and what we expect that's going to mean for the future of healthcare delivery.
The utilization of more non-invasive procedures like endovascular repair comes down to the identification and making sure that the patients are scheduled through an elective procedure versus trying to repair a burst aneurysm in an emergent case. Luckily, what we saw in our research, over 70% patients are going through the scheduled procedure route, which have a mean length of stay in a hospital bed that's about a fourth of what an emergent case is. So we're already freeing up beds there. And more importantly, for the patients, half of the days in an ICU and half of the risk for readmissions in 30 days.
Welcome to Sg2 Perspectives. I'm your host, Jayme Zage. Today, we want to focus on clinical innovation. It's really an important part of implementing strategy in terms of improving our clinical and operational performance. Clinical innovation is one of the ways that we can do that. We are going to use some of our recent research regarding abdominal aortic aneurysms to share our perspectives on how innovation can improve performance. I am joined today by two cardiovascular experts, Matt Sondreaal, the abdominal category leader for W.L. Gore and Associates, and my colleague, Walter Holbein, a consulting director at Sg2 Life Sciences Consulting Team. Welcome, Matt and Walter. Let's get started by setting the stage here because we're getting pretty deep into a clinical area. So let's make sure we start with an understanding of AAA, abdominal aortic aneurysm, and why it is an important growth program for health systems and why it has been a challenge to treat these patients.
One of the first things that we want to discuss is actually that cardiovascular disease in general is still the leading cause of death in the United States population. That's only going to increase with the aging population that's happening over the next 10 years. With that increase in the aging population, you're going to see increases in prevalence of not only normal cardiovascular diseases like atherosclerosis, coronary artery disease, but also the aortic diseases that we're going to be talking about today, especially aortic aneurysms. When we think about what that increase is going to look like, this is also going to increase with complexity. Age is one, lifestyle, sedentary lifestyle is going to have an impact, and other comorbidities as these populations become older and have other diseases on top of that.
Matt, there's a lot of innovation in the endovascular space. Why is this so important to get endovascular treatment into these programs?
As the preference for a minimally invasive treatment option has increased with time, we've recognized the need to innovate on our technology to enable physicians to treat more complex patients than they may have historically treated. Be that the patients have highly angulated anatomy or aneurysms that encroach on very important blood vessels that branch off the aorta that feed your kidneys and other really crucial organs.
That's a great setup, lay of the land, and why we're talking about AAA programs here. Our health systems understand that the innovations alone in the procedure are not going to be enough, and that AAA intervention is no different. As we think about these AAA programs, what other services need to be in place to support these patients before the intervention?
Screening these patients is incredibly important. Identifying, diagnosing, and following up on the treatment of AAA patients is essential for long-term positive outcomes. Without proper identification and intervention, you're looking at a highly complex case that when it comes into an emergency room requires a broad array of resources. And the mortality rates are exponentially larger than the identified elective surgeries that we're suggesting in this patient are the right option to go for. Not only is screening critical, but identifying and communicating between the different teams associated with the care of these patients makes the difference outside of the technology of a minimally invasive treatment.
Walter, an important part before the intervention is making sure that the physicians and the care team are current with the training requirements, as this is a rapidly evolving space where new technologies are introduced, new techniques are derived, creating space for physicians to have peer-to-peer learning opportunities or stay up to date on the technology via hands-on deployments in a virtual simulation or 3D printed patient anatomies to rehearse a surgery before going into the actual OR. Those are very complex areas that we're trying to invest in as a company. As your research showed, the volume of procedures is greatly outpacing the growth in the specialties that treat these procedures. How do we bring these educational opportunities and content to your physicians at an on-demand fashion so they get the right training when they need it to help improve outcomes over time?
It's not just about the care continuum, but it's also about the training and skill development of the clinical team. Not just the physician who's doing the procedures, but the entire cath lab team or OR team if it ends up being a surgical procedure. That has been the classic with any new technology adoption, is to make sure that everyone knows what their role is in that procedure room. I want to go back to the screening just a little bit, Walter, and let you expand on that. When we talk about screening and patient identification, how is that done?
This would be with non-invasive measures like ultrasound scans, looking at the different anatomies within the vasculature that you're looking for, angiography, as well as any supervised exercise testing as well, trying to identify problems that may be occurring within these patients earlier. Normal guidelines dictate an identification and screening past the age of 65, where most of these aneurysms do tend to happen. If there are histories within the patient's family or other comorbidities, an additional screening might not be a bad thing if you can catch an aneurysm earlier and prevent an emergent case.
We've talked about what happens before the surgery or the procedure. And in this case, thinking about the endovascular procedure and the education needed. But what happens after the patient has had an open procedure or it's an endovascular procedure? What is important for ongoing management of that patient? Matt, you're up first.
With any of these treatments, long-term follow-up is required and it's part of the care continuum. We want to see these patients back to make sure that the treatment was effective and that any issues that could be identified are found in a setting where it's non-emergent. So the patient and physician can come up with a care plan tailored to their needs to ultimately prevent rupture or moving into a more emergent setting.
It's a great idea. And especially with the longer term follow-ups, it's not only about the endovascular procedure. It's also about these patients are going to have a lot of comorbidities with this treatment, or in addition to treatment of aortic aneurysms as well. Making sure that the care and the follow-up not only address the endovascular procedure, but also the concomitant procedures as well. Thinking about diabetes or other cardiovascular diseases that may be happening together.
I could add hypertension and a slew of other challenging complications with vascular disease.
What's the risk for the patient post-surgery that the ongoing monitoring is important for, beyond just chronic disease monitoring? What specifically with the aneurysm that needs to be monitored? Is there a risk of it reforming?
Your anatomy is kind of always changing throughout your life. As it moves around, we want to make sure that device is not moved around within the anatomy as well. That way, we're still putting blood through the device versus into that compromised aneurysm sac. In follow-up, we're looking to make sure there aren't any channels for blood to flow into the aneurysm sac to repressurize it and bring back that risk of rupture for that weakened section of anatomy. And capturing those potential leaks early is helpful in creating a strategy for how physician wants to treat that leak, be it through another endovascular procedure or maybe even moving into an open operation if necessary.
We've talked about AAA programs, the continuum of care, how to make sure that clinicians are educated. I want to go back to this concept of innovation driving quality improvement. And Walter, this is where your research in this space hit home and showed some value of performing AAA repair endovascularly from a clinical outcomes perspective. Do you want to share a little bit of that research with us?
That's a great segue. The utilization of more non-invasive procedures like endovascular repair comes down to the identification and making sure that the patients are scheduled through an elective procedure versus trying to repair a burst aneurysm in an emergent case. Luckily, what we saw in our research, over 70% patients are going through the scheduled procedure route, which have a mean length of stay in a hospital bed that's about a fourth of what an emergent case is. So we're already freeing up beds there. And more importantly, for the patients, half of the days in an ICU and half of the risk for readmissions in 30 days. All of these things together are great for the patients, but they're also great for the health system to make sure that they have the beds and the resources available to treat additional patients down the road.
Did your research look at post-acute placement? How many of these patients who get procedures end up in skilled nursing versus being able to go home?
We looked at more post-procedure cases as well as outcomes with additional volume.
Let's talk about innovation more generally. We've spent some time showing that innovation in this space has reduced length of stay, reduced ICU stay, presumably also reduced patient recovery overall, that length of time even after discharge, and readmission rates, complications as a result by innovating the way that we do the care. Let's talk more generally about innovation and how should we make decisions on which innovations to develop and adopt.
When we think about innovation from the health system perspective, the goal is around the number of patients that are eligible for these less invasive procedures and increasing that number. Can you take on more complex procedures that aren't available today using your new technology? Are you broadening the amount of physicians that are able to use the device because it's easier to deploy and it's safer to use? All of these pieces get us to treat the patients that need these procedures done and make sure that it's done in a less invasive manner.
We looked at it as needing to provide additional treatment options for physicians for more complex patients. Previously, patients may not have been able to get minimally invasive surgery if their anatomy was too angulated or if they're diseased, encroached on important branch vessels of the aorta that feed your kidneys or your liver, for example. Developing technologies to cover a broader swath of patients was imperative to us as a med tech company. We see the ability to improve outcomes from treatment through follow-up by developing those technologies. But Walter, your research was really important in showing how we increase the total outcomes of the society by having robust screening, identifying patients in an elective setting so they can come up with the right treatment plan for each patient. So that way we're not rushing and dealing with these pathologies in an emergent or ruptured setting where it's a life-threatening condition. And we've seen how the outcomes change between the two in your research.
The piece around identifying early makes a lot of sense. The importance of not only having an integrated screening criteria within the hospital and within the acute care setting, but broadening that out to primary care that are going to have that first touch with the patients and promote the idea of getting a preventative medicine screen to identify potential risks with these patients. Having that integration along the entire continuum of care versus only focusing on the cardiovascular experts is going to be critical for long-term success of these aortic aneurysm programs.
Maybe an important detail for aneurysmal disease, just because you've screened a patient and found an aneurysm doesn't immediately mean that they have to be treated. Oftentimes there's the ability for physicians to follow patients with an aneurysm to treat them when they become the right size or shape or in a more controlled and planned method versus a reactive setting if that aneurysm comes back with the rupture.
What I'm hearing in this value of innovation is that one little technical innovation in a device or a therapeutic approach has a halo effect of potentially changing the entire care continuum, how we approach the patient, how we bring them into the procedure itself, how we bring them into that care continuum, what that care continuum looks like, which patients are eligible. So expanding patient eligibility, expanding access to interventions, because now it's easier for physicians to do it, which means maybe potentially available at more sites or in more locations within a market so that now you've got greater access to the procedure. Just by changing how we deliver an intervention has this ripple effect across a whole strata of things that can move to improve the quality of care for patients in a community. Thank you, Walter and Matt, for sharing your expertise and for not getting too clinical for those of us who have more strategic hats. This has really been an interesting discussion for me. It goes back to my science roots and looking at the underlying components of disease here. I learned something through your paper, through the discussion. I appreciate that. And to our listeners, if you're interested in the research that Walter described around AAA, it is a publication that's available. We're going to link it into our show notes for the episode summary. And you can also email us at sg2perspectives.com, and we can work to get you a copy that way as well.
Thanks for listening. If you like this episode, please subscribe, rate, and review us, and or follow us on Twitter and LinkedIn at SG2 Healthcare. And if you want to talk more about innovative healthcare strategies, you can always email me at sg2perspectives@sg2.com. Finally, SG2 is a Vizient company, and there are a bunch of Vizient podcasts that you might like. You can find them at Vizient /podcasts. Have a great day.